Hi, my name is Ananya. I am one of the associate editors of Gastrointestinal Endoscopy. I'm here today with Dr. Thomas Abell. He's from University of Mississippi. We are going to talk to him about one of his upcoming publications that are going to show up in Gastrointestinal Endoscopy soon. It's about development of a innovative technique for endoscopic implantation and securing of a novel wireless miniature gastrostimulator. Dr. Abell, thank you for coming here and be willing to talk about your paper. It's very interesting, definitely a breakthrough area in gastroenterology. All of us kind of struggle to treat patients with gastroparesis without very limited medical interventional abilities, and I think this is going to go far away towards that direction. Tell us a little bit about the study that I know that you have done a few more sequential studies.
A little background, and thank you very much for inviting me. And I wanted to thank also my co-investigators, including Dr. Tang, who you know. And basically, electrical stimulation has been useful for symptoms. And over the last decade, we've developed a way to place it endoscopically, but it involves a wire. That was published in Gastrointestinal Endoscopy last fall. And the wire has a number of drawbacks, not only discomfort, but also limits the length of time it could stay in. So what this was one of a series of studies trying to look at a wireless device that would have the battery in it that could be implanted endoscopically. And this particular study focused on various ways to attach that device on the mucosal side with endoscopic implantation.
Sure. And I looked at the paper, and it seems that you used like 5 different ways, like clipping it, tacking it, doing like a T-tube, a tack tube T-fastener kind of a situation, then spring coils, and then you interestingly did a submucosal tunnel to place the device. Any particular preference, and if
well,
so,
I think at this point it's not clear what's going to work best, which would be a focus of future work, but probably the easiest would be just to attach it with a kind of clipping device. The problem is it doesn't take that very close to the neuromuscular apparatus that you'd like to attach to. So we then looked, as mentioned, into tacks, various kinds of coils, other wires, and the submucosal pocketing, I think, probably is in some ways the most intriguing because number one, there's increasing experience with Dr. Tang and others with submucosal dissection, and a lot of endoscopists have experience with that, but that also offers the potential to literally bury that without surgery.
Yes.
The other approach that I could back up a little bit is there's also a percutaneous approach, which we didn't look at, but that has the drawback of wires coming out the surface of the stomach, and again, we've decided that would be less than ideal for patient comfort. Our focus has been something that can be placed endoscopically and thus used for short to intermediate term use.
So I know it's a little premature to talk about it. When you talk about short to intermediate, what kind of time frame do you think for clinically for when it's ready to go for patients?
Well, the batteries can be delivered, and that was in a previous paper in GIE. The battery can be either with an internal battery that's recharged externally, or with the battery actually being external. So with those, you could potentially have a long period of time. Another approach would be to use a battery that's self-contained, which we usually would have, with current battery technology, probably a several-month duration. One of the attractions would not only be for patients to try something for a little bit longer than the current time, but also there may be some disorders, for example, cancer chemotherapy, that would be relatively self-limited. Going back to our study last fall in GIE, that wired device only stayed in about a week, and many patients have symptoms that are somewhat cyclic in nature, and a week isn't necessarily long enough to see if it's going to help, much less therapeutically.
Sure. And from a technique point of view, where do you think that will be the the device should be placed and will work best in the fundus of the stomach, body,
Good
or
question.
more distally?
Most of our work, which goes back, animal work goes back almost 30 years now, has been in the body antral junction. Now we have an article that's coming out in another journal called Gastroenterology, just accepted, using a high resolution mapping with 256 electrodes. And that article shows that area that we've targeted seems to be the area that's most electrically active. There are abnormalities that can occur anywhere in the stomach, but that is a likely area. It's also pretty accessible endoscopically, both directly as well as percutaneously if you use a percutaneous approach or fasteners.
And these are non-survival experiments, so you probably have to do some survival experiments at some point of time.
Yeah, and although it's small, but obviously would need to be developed and literally and figuratively smoothed to be able to use it for human trials.
And when you do the stimulation, the placement of the device, is there any comparative data about which type of fixation or tacking it to the gastric wall gives the best stimulation?
We don't have any data at this point, but that would obviously need to be a focus of future surviving studies to compare.
Sure.
If one is better than another, then we clearly would focus on the one that has the best outcome.
Very good. Yeah, no, this is a very interesting area of development, and we will be watching it very closely. And congratulations for working on this exciting area.
Thank you, and thank you, my colleagues, and the opportunity to talk.
Sure. Thank you.